My name is Luca Tomasetti. I'm a PhD student at the University of Stavanger, and today I'm going to talk about my latest research. So, as you can see, the title of the latest research, it's full and dense of a lot of different topics. So, before starting going into details, I would like to focus on three different aspects, which are the multi-input, the acute ischemic stroke, and the slow fusion approach that we are using. First of all, what is an ischemic stroke? An ischemic stroke is a very serious medical condition that can occur if the flow of oxygen-rich blood is occluded to a portion of the brain. And a patient that suffered this condition immediately suffer from different symptoms, such as visual loss, unconsciousness, paresis, or difficulty in speaking. So it's very important to act quickly here. And as you might know, a cerebral stroke is the second most common cause of death among adults worldwide. This was like a reference from 2018. So I don't know exactly the numbers after the COVID situation. Probably it's not the second. It's not the second most cause of death right now, but still it's among the. It's very high rank still. After an ischemic stroke, two regions can be defined, which is the core and penumbra. Core is can be seen as dead tissue, while penumbra can be seen as hypoperfused but still viable tissue. Medical doctors during their treatment trying to assess and understand how the penumbra can be saved from and make it the tissue of the brain still viable. Thus, an automatic, fast, and correct visualization of these two areas, the core and penumbra, can be really helpful for medical doctors for their treatment planning. In order to understand and to assess if a patient might be affected by a stroke, normally, computed tomography is one of the recommended modalities because it's cheap, it's fast, and has very few contraindications. At Stavanger University Hospital, they use an analysis called CT perfusion, which is formed by acquiring 3D CT scan of the brain at many time points during the injection of constant agents in order to highlight and enhance the brain tissue. So the goal of the CT perfusion is to assess the ratio of infarct core and penumbra. At the end of this study, at the end of this CT perfusion study, different parametric maps are generated in order to visualize and to understand different information of the brain tissue. And these different parametric maps show the neurologist if there is an ischemic problem or not in the patient. So enough with the ischemic stroke. As I mentioned in the beginning, we also want to focus on the multi-input that we're using, and the set of parametric maps that are generated from the CT perfusion study are used as our multi-input for the proposed method. Also, in addition to this set, we're using a maximum intensity projection images and plus a NIS score, which gives information about clinical severity at hospital admission. So what we create and what we propose is a method similar to a UNet. But as you can see here, instead of using just a single image as our input, we use a combination of a different set of parametric maps as input, feed it to a number of VGG16 in the convolution net that varies depending on the experiment that we're performing. And all of these features extracted by the VGG16 are concatenated in a single deconvolutional part, as you can see on the right part of the figure. And the slow fusion approach is using to extract local feature from the VGG16 separately. So each parametric map, each image is extract feature by themselves, but then they're concatenated together using skip connection and feature connection. and feature concatenation, sorry, in the deconvolutional part. So what we have at the end is a multi-input that generate a single two-dimensional image containing the different region that we want to segment. Our dataset is composed of 152 patients divided in 3 groups based on their level of vessel occlusion. So we have 77 patients with large vessel occlusion, 60 patients with not large vessel occlusion, and 15 patients without ischemic stroke. They were admitted at the hospital with a suspected ischemic stroke, but they turned out to have not anything. So we have this kind of generalization of the dataset in order to simulate more, to train our network to have a more real life situation. So we have different patients with different level of severity for the network to be trained with. However, 152 patients is not like a high number for a dataset. So we use also transfer learning using layered weight pre-trainer with ImageNet dataset in the VGG16 layer weights. And also, as the majority of medical dataset has, also our dataset has like an imbalance problem. So for overcome this issue, we focus on 2 different aspects. So we focus on the non-LVO group during training, and we also try to focus on a specific loss function. When I say that we focus on the non-LVO group, it means that during training and only during training, if there is a misclassification or missegmentation of one of these patient group, we try to have a high penalty if there is a misclassification, only for this non-LVO group. While the loss function is being generated by a research group mainly to attack this class imbalance in medical dataset. So what we try to use it is called focal Tversky loss, which is, as you can see on the bottom left, is based on focal loss on the Tversky index. The Tversky index is a generalized version of the Dice coefficient function that you can see on the right, but together with the Dice coefficient, we also has 2 parameters that can be changed, this alpha and beta. We perform a lot of experiments using to understand if the model that we propose is optimal. So first of all, we're doing a hyperparameter optimization on the focal Tversky loss, on the parameter of the focal Tversky loss, so gamma, alpha, and beta, to select the parameter that gives you the most interesting results. And we also perform different experiments using a combination of the multi-input that I showed you before. We also changed the layer weights between different settings, so between frozen and unfrozen, or a gradual fine-tuning as we define them. And also we try to perform an additional experiment to see if the slow fusion approach that we use is suitable, or we need to change it to a different approach, like such as an early fusion approach. So first of all, a hyperparameter optimization is performed following the idea of the original paper of the focal Tversky loss. So we have different ranges for the different parameters that we try to check. So for gamma, for example, must be greater than 1. So we try in a range between 1 and 3, because we saw that results are larger than 3, then gamma larger than 3 give you lower results than before. So we try to keep it within this range. We also check different combination in the parameters alpha and beta, and these parameters need to be between 0 and 1. As you can see from this table, the most satisfactory results from this hyperparameter search is given by gamma equal to, don't know if you can see my pointer, maybe, but it's given by gamma equal to 4/3 and alpha equal to 0.7 and beta equal to 0.3. These results are given by the statistical evaluation of the Dice coefficient on average over all the groups that we have in our dataset. Second of all, we have done an additional experiment with the combination of the multi-input that we have, and also with the different setting for the layer weights. So we have run the different inputs such as the set of parametric maps or the set of parametric maps plus the MIP images or the NIS score. And we also try to differentiate the setting of the layer weights. So first we try every layer weights in the VGG16 in the convolutional part being frozen. Then we change everything to be unfrozen, so to be trainable. And at the end, we also try something like in a hybrid version of between frozen and frozen. So everything started as frozen, and then we slowly change into everything, all the layers to be unfrozen, checking the validation loss during training. And we see that, as you can see from this table, the best model is given by this gradual fine-tuning approach using parametric maps and NIS score as input. The one highlighted with the red rectangle at the bottom of the table. Finally, we also wanted to check if our slow fusion approach, the one on the left, is the most suitable for this task. So we compare the results with the same hyperparameter, with the same kind of layer weights and combination of input using early fusion and early fusion with depletion model. The early fusion model is all the inputs of this early fusion model are concatenated together over the channel axis before be fed to a single VGG16. So these follow more like a normal UNet structure, while the early fusion with inflation approach, the inputs are concatenated over a fourth dimension. And this idea followed the I3D network by Carrera et al., where they introduced in their research a video classification model with an inflated ImageNet image classification architecture. So they try to, what they've done is they remodel all the filter and pooling kernels from square to be cubic. So they try to create some kind of in-play 3D VGG16 for their convolutional part. We saw that we run the experiment with the same kind of input, same kind of parameters in order to have like a fair comparison. And we see that overall the statistic methods that we evaluate, so Dice coefficient, difference in volume, or Hansdorff distance, we see that our model with the slow fusion approach is the one that gives you the most satisfactory results. I forgot to mention that all the results that you have seen in the table are based on the validation, our validation set, because we saw that in order to choose the best model, we don't want to use the test set because that is secret, that is kept in a separate way. So we want just to use the validation to actually select the best model and then use the test set to see how good or how hard our prediction. So what we've done here is use this is the results for the test set, just the test set. And we try to see the prediction of our selected model, the slow fusion approach, in comparison with annotation generated by two neuroradiologists. In this table are named NR1 and NR2. And we see that with and we check the Dice coefficient on average over the entire test set. Furthermore, we try to understand the inter-observer variability of our results. So we try to understand the annotation made by the radiology by themselves. So you can see here on the second row NR1 versus NR2 to see how the inter-observer variability results are in comparison with our prediction comparing to the annotation of the neuroradiologist. Also, we would also like to understand how good our predictions are in comparison with single neuroradiologists. So to better understand how the model perform comparing to a expert neuroradiologist. And we can see that the results are pretty similar to each other. Okay, but enough with statistical results. I would like to show you also some visual results because also the images are better than just tables. And you can see here, these are 6 patients from the test set. As you can see, the prediction are given with a light gray color for the penumbra and white color for the core. while the ground truth is given by like this blue contour for the penumbra and red color for the core. As you can see, most of the results are satisfactory regardless of the group. So regardless of it being like a large vessel occlusion group, non-large vessel occlusion group, or even without any ischemic stroke. But I would like to focus a little bit on, not on the good part, but on the bad part, because here you can see that there are some false positive prediction for penumbra. And I don't know if it's possible to notice very well from this slide, but the input here of the parametric maps contains artifacts because of the way they are generated. So we assume that these false predictions are given by the fact that the input contains artifacts. So this is something that I will focus on the next research though. But in conclusion, the proposed model achieved promising results to segment most of the ischemic region, regardless of patient severity. But the false positive result that you have seen in the previous slides might be avoided using the entire 4-dimensional CT perfusion study, which is the focus on the next research that I'm working on. These are the references.